Thank you very much, and thank you for giving us the opportunity to present work that we're carrying out not too far from EPFL in Saint-Sulpice, in collaboration with interns that we regularly host and that are listed here at the bottom of the slide, two of them having become since permanent employees. First, let me situate the concept of comorbidity within the world of pharma and medicine. As you know, randomized clinical trials are a cornerstone of innovative treatments. However, phase 3 selection criteria are often engineered for a successful financial outcome. As a consequence, the avoidance of comorbidities creates a selection bias that overestimates the therapeutic effects of new drugs. If you look at the literature, multiple morbidities are common. In fact, in the US, the average age-adjusted mean number of comorbidities is about 2.2. And 75% of adults with diabetes also have hypertension. In the UK, midlife individuals have multimorbidities in about 1/3 of the cases. As a consequence of this randomized clinical trials, the medical guidelines are generally formulated for single morbidities. And the superposition principle is not always adequate. For example, a hypercholesterol patient may get statin to reduce the cholesterol and as a consequence develop diabetes. So the question that we're asking is, what is the optimal therapeutic response for a comorbid patient? This in terms of drugs, sequence, and dosage. At Metadvice, we develop AI for complex disease management. We generally use guidelines and data to formulate diagnosis and therapy recommendations. We apply clinical guidelines and master exponentially growing literature. We evaluate multiple factors and justify the decisions to regulatory bodies. We're also active in precision medicine, performing individualized recommendations. First of all, pointing out missing data or outdated data, identifying high-risk patients and poor responders to therapies. And we justify these recommendations with peer groups. In short, we help doctors who have too little time and too much work to explore all these multiple avenues. Our AI, in principle, is a Bayesian transfer learning pipeline. We start from electronic medical records and documents, extract phenotype, genotype, analysis, and therapies, and feed these into neural networks. These neural networks are bootstrapped with clinical knowledge and then transfer learned into data from real patients. As an output, we then are able to highlight the clinical guidance that is relevant for an individual patient and also identify smaller cohorts of similar patients where the guidelines are actually not the best avenue. What is important is that we really teach the neural network medicine before training it with patient data. In terms of modeling the comorbidity, think of a linear approximation. A neural network, if you approximate it in a linear fashion, will become a matrix. In yellow, you see the features corresponding to a first morbidity A, and in red, features corresponding to another morbidity B. There's actually one point in common in orange that is a feature that is common for both morbidities. A real patient, in general, will have measurements corresponding to both of these morbidities. Sometimes some features will be absent, and sometimes there will be extra information that may actually help in discriminating between these morbidities. So in principle, the problem of formulating a comorbid model is simply to calibrate the values in this matrix for a linear model or the weights for a neural network. For that, However, we need a common objective function that overlaps both the models A and B. In terms of objective, we try to maximize the therapy efficacy. For single pathologies, this is relatively simply said. In hypertension, you can, for example, target a systolic blood pressure below a certain value, or in diabetes, the same for the high glycated hemoglobin. In cancer or multiple myeloma, which is another example here shown on the right, you generally try to maximize the progression-free survival. That's the duration over which the cancer essentially does not progress. And you can quantify the or assess the efficacy of therapy, which is here very complex with multiple drugs, by quantifying essentially this time of progression-free survival. Alternatively, you could also use overall survival, but the number statistics then drops significantly, which is often a problem, especially in cancer. In comorbidity, however, the problem is a little bit more complex, and you need to have an objective function that overlaps the underlying morbidities. And generally, what we use is the avoidance of the escalation of joint outcomes. Let me give you here a first example with a single morbidity, using a model for hypertension to avoid the escalation as developed by Evan this summer. Starting with clinical guidelines here, nice because it's a UK study. He was able to formulate a neural network that reproduces the guidelines roughly with 96% accuracy. It's a perceptron with 4 layers and 14 neurons. This model is appropriate for the patients in average. That means the majority of the patients. He then used a transfer learning technique to basically retrain that model using 50,000 patients from clinics around London. And you see on the right how the different therapies or the counts per therapy evolve as you retrain the neural network. As a result, he was able to gain a little bit in accuracy, going from 47 to 50% of essentially target achievement, which is, if you want, a good result. However, it's still surprising that only 50% of the targets are actually achieved. That's not what people generally have in mind when they go to the doctor. So the question is, can we improve on the result, which is really something that is common, given that we're roughly exposing here the guidelines. Nicolas just minted his master's thesis dealing with a comorbidity model combining hypertension, diabetes mellitus 2, and hypercholesterolemia. And he used 3 models: random forest, neural network, and then neural network with guidelines, to essentially achieve something around 70% accuracy with sensitivities and specificities roughly equal. He then looked at the most complex of these models, where the neural network has been bootstrapped with guidelines and then retrained with data, to see how much training is necessary, or how much transfer is necessary to optimize the achievement of the target. And you start, if we transfer no of the patients, that means we apply strictly the guidelines, you see that 64% of the patients have an avoided escalation. However, if you start transferring part of the patients and identifying smaller cohorts that do not behave like the guidelines, he was able to achieve as much as 68% achievement of the target. That means an avoidance of escalation within the 2 years. And I should emphasize here that this has been calculated on 350 patients that were not used when training the models. The question that comes about is, why do we now recommend something different than the guidelines? What is the justification? And to answer this question, he looked at three models, three neural networks, one bootstrapped only with guidelines, one with guidelines and then retrained with data, and then a third neural net trained only with data. And what he observed is that when the neural net has first been exposed to guidelines, the top features in shapely values roughly coincide. Whereas if we use data only, the top features that come to the conclusion are actually quite different. What I should say also is that all these three models roughly come to the same conclusion. What we then found is that in principle, the neural nets behave a little bit like the medical doctors. It's better first to go to med school and understand a little bit of medicine before you get to practice on real patients, because you will then learn knowledge that is transferable between the clinics, because people eventually are the same whether you go to clinic A or B. If you train on data only, you learn features that are very local to the clinic. For example, a nurse may be practicing only on Thursday, and the machine learning model actually learned the fact that on Thursday it should behave differently, which is obviously not medicine. So training with guidelines makes the artificial intelligence more portable. Looking at a single precision medicine recommendation, we try to figure out what makes basically the neural network decide not to follow the clinical guidelines. And what we found very often is that it's not a single factor that determines the difference in the outcome. It's actually a large number of dimensions that need to be assessed, something that a human really cannot achieve. So this makes sense and is reassuring in terms of our recommendations. Last example that I want to give is in cancer. So this is multiple myeloma, where we looked at first-line therapy called Velcade Revlimid dexamethasone, and has a progression-free survival according to clinical guidelines, or clinical trials, I would say, that is much longer than observed in reality. So we looked at the Vanderbilt University Medical Center in the US and found that the progression-free survival simply is lower than the trials. And we found that the most likely cause is the presence of comorbidities, exactly these comorbidities that were avoided in the clinical trials. We then formulated a machine learning model that basically is capable of predicting the bad responders. And we're working on justifying alternative treatments, trying to propose something better to those patients who actually don't respond to treatments. And I'm unfortunately not ready yet to propose a good solution. We're still battling with statistical significance on this topic. So I should conclude here that we showed you a couple of examples in the case of comorbidities, and that we're able to do better by treating several morbidities together than a single one. Small cohorts of patients will benefit from following precision medicine recommendations. What we're facing now is that in real clinics, we need to convince doctors not to follow guidelines for these specific patients. And how to achieve that remains an experience that is ahead. That's it. Thank you very much for your time.
Thank you very much, André, for sharing this really interesting work. So we have a few questions. So one is on, you talked about that you're teaching medicine to the neural network, and also subsequently talked about bootstrapping neural networks with guidelines. And if I were to understand correctly, guidelines are more like rule-based, that more rule-based kind of instructions that are then used in the clinical practice. So the audience and also myself quite curious as to what does it mean by training a neural network on a kind of a data set that is more rule-based like.
So eventually the rules are set in the text. So guidelines are written documents that need to be interpreted often by humans. And we basically have to extract this knowledge from the documents. And we use a variety of techniques to basically extract this knowledge and infuse it into the neural network.
Okay, got it. And then the next question is more about if we look at, so if you're looking into now bringing in data and combining it with learnings that you have from the guidelines. Now, if we see from a real world practice perspective, there's always a difference, sometimes a lag, sometimes let's say there might be institutional policy to use treatment A versus treatment B due to reimbursement. So how is the system then catering for those differences that are kind of inherent in medical practice?
It's a difficult question to answer, and I think I will be ready to answer it once I have, deployed the tool in a variety of environments. We're currently deploying it in London, and maybe once we have it in Switzerland as well, I'll be able to give you a better answer.